So it's really a pleasure to be here. And the importance of this is that we cannot achieve anything in the sepsis world, and in fact, unless we have very good advocacy. And I think that that's so important because as clinicians, we can do very good work. We can produce very good papers. We can sort of set up clinics, et cetera. But unless we advocate to find the resources that will allow us to do the work, I think it's all going to be for very little. We will not achieve our full potential. And in fact, it has been said years ago that advocacy for a disease is like a political campaign. You got to have mascot, icon, celebrities, etc., to win the battle in the corridors of authority and power, to win it at the bedside. And what is important here also, I'm going to have three very good friends of mine who would be on this panel to talk about advocacies, different aspects of it. Each one will have 10 minutes to talk. We'll have 5 minutes for questions, and then hopefully we'll have some time for questions in the end. And as you heard, I don't have to introduce myself much more. I'm Tex Kissoon. I'm president of the Global Sepsis Alliance, and I'm very pleased to be here. Now, the first speaker, without much ado, is my good friend who works with me at the Children's Hospital, Manish Sadarangani. Now, Manish is the director of the Vaccine Evaluation Center at BC Children's Hospital Research Institute, an associate professor in the Division of Infectious Disease. Now, he's also encompasses a unique combination of laboratory work, clinical and epidemiological research. And his research identifies high-risk target immunization populations and programs and evaluate vaccine effectiveness to inform evidence-based policy. Now, we are very, very fortunate to have Manish at our institution. And especially at this time where there is so much resistance to vaccine and so much false information out there, I know he has been in the forefront of changing that around. Another fact that many people will not know, Manish, I understand, joined a Caribbean soccer team, although is not from the Caribbean. But we are very proud to have him even on that soccer team. I'm not sure if he scored a goal at any time, but we'll let that pass. So without further ado, Manish, I'll turn it over to you.
Thanks, Tex. Thank you for your kind introduction and also for the invitation to speak. So I still am on the soccer team. I have not scored any goals this season, but it'll come. It's still early days in the season. I'm also very jealous of your blue sky and mountains. I can't even see the mountains out of my window in Vancouver today, but just grateful it's not raining. Anyway, yeah, so I was asked to speak on under this broad umbrella of engaging communities in sepsis prevention and policy on vaccine policy progresses and challenges. And it was hard to know what to cover in 10 minutes. And so I think if I'm not covering something that you would have liked me to, I'm happy to take questions on it in the Q&A period. So just my disclosures, I have some salary awards from various people provincially, and I've had some projects funded by industry in the last few years with funds going to my institute. So most of what I'm going to talk about is around how the advocacy works for us in relation to our research. And so just to sort of ground you a little bit in terms of the research that we do at the Vaccine Evaluation Center. So I describe this as sort of from molecule to population. And so we do population level studies to try and, do surveillance to establish priorities for new vaccines. Sometimes that comes and hits you on the head like a sledgehammer, like it did for COVID. Sometimes it's less clear. We have lab-based discovery in terms of infection pathogenesis, vaccine design, preclinical vaccine studies in animal and in vitro models. On the clinical development side, studies to look at vaccine safety, efficacy, immunogenicity in phase 1 to 4 clinical studies, lab work to look at immune responses and particularly protective immunity from those clinical studies. And then finally, implementation. And I think a lot of the advocacy, whereas people will think about it in this implementation space and how it, because at the end of the day, the vaccine's not doing anything on the shelf and not preventing any cases of sepsis if it's sitting on the shelf and no one's having it. And so while that's what a lot of people think about, I think, I think about it through the entire life cycle here of a vaccine, and I'll show you some examples of why. So I think from my perspective, this engagement has to happen from all stakeholders at every step. And I like this figure, which is, I didn't make this is produced by another group in BC, but all the way from at the beginning here, when you're identifying priorities, planning your research, getting funding, recruiting people, starting your project, recruiting participants, collecting data, interpreting the data, and then sharing the data. I think it's really, really critical for but not only for the advocacy, but also to ensure good quality, relevant research, that we include our community partners, policy partners, and other relevant stakeholders at every single step. And I think you can see this is not a straight line. It's a very, winding road that sometimes goes back on itself, and things, can work or not work, and it's iterative. And so, and I'll show you some examples of how we have done that in some of our work. So this, I go back to, a small project that we did that was supported by the Michael Smith Foundation, now Health Research BC, in the midst of the COVID pandemic, where we really went out to our stakeholders and to the community to say, actually, to ask them, what do you think we should be doing and how should we be doing our vaccine research in British Columbia? And it was really about listening and learning on the premise that most vaccine research is designed by researchers without the engagement and expertise of the public or healthcare providers or policymakers. And so we had a series of discussions with these research users from diverse backgrounds to try and help us to prioritize the knowledge and evidence gaps for vaccine research. And what they told us was that there was a perception of a lack of collaboration with all of these partners, and specifically including Indigenous populations and vulnerable youth. A lot of gaps in the public knowledge and healthcare provider knowledge on vaccine development and vaccine research, and then particularly on special groups who need vaccines, like in pregnancy or medically complex or immunocompromised patients. The dissemination, there were some gaps in terms of, in a busy healthcare provider setting, how do they effectively receive vaccine updates? How do they effectively communicate this with the public? How do we directly communicate this with the public? How do we get through the conflicting messaging? And again, I remind you, we were doing this during the middle of the COVID pandemic, where the messaging was frequently changing because the science was frequently changing, and that leads to conflict, some of which is real and some of which I think is perceived. But that in itself leads to vaccine hesitancy. And I think we still see this. Every morning, one of the first things I do is look at the news to figure out what is it that I'm going to get emailed about today from people. What is in the news? There seems to be something vaccine related almost on a daily basis. And around surveillance specifically, that the lack of, with our slightly fragmented healthcare systems in Canada, where it is done provincially, territorially, lack of national systems to do some of this monitoring, which again underpins safety and vaccine hesitancy. So, I talked about stakeholder involvement from end to end, and this is just a couple of examples. So this is a study we did on parent and healthcare provider views of live varicella vaccine in children with solid organ transplant. And just to give you a bit of context, so this is, these live vaccines, so this is a chickenpox vaccine, are normally contraindicated in immunocompromised children, including solid organ transplant. There's been a shift in some of the guidelines to do that we can now do it safely, but it's a complete culture shift in this community, both from the families and from the healthcare providers, having told their patients for years that this is not a safe vaccine to give, that we're now saying it's safe. And so we did this work to try and understand how we would need to do that from an implementation piece. And one of the reasons I highlight this is to highlight Elaine Young, who was our patient partner, and she was involved from designing the study, a co-investigator on the funding application at every single one of our investigator study meetings, helped to implement the project, and then also, as you can see here, co-author on the manuscript. And so I think not only was this, the topic was around the parent and provider views, but we had, Elaine there throughout the process, as well as a number of other experts. And then this is a study that we currently have ongoing. This protocol has just been published on a study we're doing to evaluate the HPV, human papillomavirus vaccine. And there's a number of, as well as the researchers here, there's a number of individuals from public health who ultimately are the ones going to be making the policy decisions. And so it's really important that we have them with us to make sure we're answering the right questions that they can use in the decision-making process. This is a screenshot from the Theresa Tam, who's recently stepped down as the Chief Medical Health Officer in Canada. This is from her report of the key players in Canada's vaccination system. And I'm not going to go through every single one of these boxes, but I think all to say is that there's a lot of groups here. And I think it's, when we do our work, we're really trying to think, how can we involve all of the relevant groups from these, these and there's others as well throughout the process from the very beginning all the way to the end. It's not just about having them help to disseminate the knowledge. I think they really have to be involved at the conception stage. This is a project that we're just embarking on. We haven't got a website yet. This is called Vaccines and Me. And so we're really, we've sort of almost, but not quite given up on the adults in terms of vaccine hesitancy and the anti-vax movement. And we're really focusing some of this work now on children. And how can we get this messaging into children to make them understand, children and youth, that vaccines are safe and effective, and steer them, I have 3 teenagers, they have various sources of information, mostly online, and how can we steer them to reliable sources? And so we actually have, our steering committee has got more youth on it than adults, and we're working with them and doing some work now to try and help get some feedback directly from the youth on asking them, what do you need? If we want to create an online vaccine resource hub for you, how should we be doing this? And we're about to embark on a series of surveys and individual and group interviews to try and hear their voice and try and design it for them. And then just a sort of final one specific thing and some work we've done, not just in vaccines, but more broadly here at BC Children's Hospital. And Quindone has really been leading these efforts to identify and evaluate and overcome different barriers. And these 2 publications from earlier this year are specifically around language barriers in pediatric research. And how do we make it easy for researchers to address these language barriers, so we're not making it hard for the researchers and we're being more inclusive in the research that we're doing. So this is some work that was led by here, but this was a national survey of healthcare researchers, and then some qualitative work on how we can, some strategies to overcome these language barriers, and just throughout the whole process, make it something that is easy for everyone to do, so we can be inclusive in the work that we are doing. So I think I bring you back to this, and it's like I said, it's a long winding road. We try to involve all of the relevant stakeholders at every single step of the way and bring them along with us. And I think what we have found is that when it comes to the final step of sharing the findings, if they've been involved from the beginning, they are the biggest advocates, and the community partners are the biggest advocates for the work that we do. And just want to end by thanking not only the team that we have here, but all of our incredible study participants, our collaborators, and all of the funders for all of the work that we do. And thanks again to Tex and the team for the invitation to share this with you today. And I look forward to the other speakers' comments and for the discussion. Thanks.
Okay, thank you very much, Manish. Are there any questions that anyone would like to pose to Manish at this time? I see Stephanie has a question there. Stephanie, do you want to say what it is, or do you want me to repeat it?
I can say it.
Sure.
I'm just gonna leave my camera off. But yeah, so I was just wondering, obviously you've done a lot of work, and in general, there's been a lot of work with vaccine hesitancy, but how can we leverage all this work to also increase awareness of sepsis and just tie together and increase awareness of the role of infection prevention in reducing the burden of sepsis?
Yeah, I think that's a good question. I think it's really, it's a really critical part of addressing vaccine hesitancy, I think, is trying to identify what the drivers of that, which are, different for different people. So for some people, there is definitely, in some of the ways that people approach vaccine hesitancy, sort of this 3 C's, and one of the C's is complacency. So complacency being really lack of awareness about the diseases that we're trying to prevent, or this sort of concept that these are diseases of the past or diseases that occur in other countries and are not a concern in Canada. And I think in some ways we're probably not great at talking about it from a sepsis perspective in the vaccine space, because people talk about specific vaccines and the diseases they prevent. So while, I might talk to a family about a pneumococcal vaccine and a meningococcal vaccine and a Haemophilus influenza vaccine, all of them, in that conversation, sepsis will be mentioned. And so, the other approach would be to bring that together and say there are multiple vaccines to prevent sepsis, and these are what they are, and there are multiple vaccines to prevent meningitis and pneumonia and these things. So I think it's really about trying to, and I think for a lot of it for me, for the patients that I see in my clinic, it's really trying to identify what their specific questions are and concerns are and address those. But I think definitely, that lack of awareness or lack of understanding of the diseases we're trying to prevent is definitely one of them.
Thanks.
Are there any other questions from the audience? So I guess I'll give you the final one then. Manish, one of the issues that it seems to be is that obviously with the internet, there are so many ways of acquiring information, knowledge, and it may be erroneous, those things. And I think that one of the things, the underlying thing you're saying is that how we communicate with families is very important. And I recall a psychologist saying that when mothers come now, it's what is called neoliberal mothering. In other words, they're going to challenge us more and ask more questions because they have more information. Maybe with that, maybe if you can just speak a minute or so about the Clarity Foundation and how that may help and how we can leverage to really support families.
Yeah, so I mean, I think, we've seen time and time again with the studies that have been done, that despite everything that is out there, the most trusted source of information remains sort of healthcare professionals. And so I think it's upon us to really advise and inform and arm us as a community and healthcare professionals with the information they need to be able to address those questions head on, right? So I think that anything that we can do to get that messaging clear to the healthcare providers, who then will be able to really amplify the accurate knowledge to their patients, is really, really important.
Okay. No, thank you very much, Manish. I think at the end, we may have time for more questions. In the meantime, it is indeed my pleasure to introduce Sandeep Maharaj. Dr. Maharaj is a distinguished pharmacist and academic leader with extensive experience spanning pharmacy administration, healthcare, sustainability, health policies, and environmental health. He's currently a senior lecturer and coordinator of pharmacy administration at the School of Pharmacy at the University of the West Indies. And also he is the CEO of the Caribbean Sepsis and AMR Alliance. It's been my pleasure meeting Sandeep a few years ago, spoke to him about this alliance. He understood it immediately and he ran with it. And I am proud to say it's one of the most vibrant alliances of all the alliances we have worldwide. He's also involved veterinary medicine, One Health approach, etc. So with that, I would like to turn it over to my friend Sandeep, who is also in Trinidad with me, but I guess we're in different parts. Sandeep, it's all yours.
Yeah, pleasant good afternoon, and thank you very much for that introduction. I don't know if I'll be able to do justice to it. And first of all, I'd just like to give a bit of a background. My training actually is in business administration after pharmacy, so you're having a business person PhD telling you all about sepsis. So please forgive me for any errors. And furthermore, I must thank a few people before I do this presentation. This is really pushed by the energy of Dr. Satish Janki. Everything I present here today belongs to him. He has done quite a lot of work in this area. And there are people and troops on the ground in the Caribbean, such as Dr. Natalie Graves, Dr. Aldit Buckland, and as well our veterinary friends in Jamaica, who really, really do a lot of work to push this forward. So it stands on that. And the inspiration for this came from Professor Kissoon, who many will know is a graduate, and as I said earlier, from the University of the West Indies, and is soon enough to be rightly awarded his honorary doctorate. So, but not much further ado, I've been given 10 minutes and I've used up one already. Let me kindly move forward. Using a One Health approach to advance the sepsis agenda. Why this is critical in the Caribbean. As you all know, and you all know the statistic, 50 people die from sepsis globally, WHO 2017, and about 11 million people, 50 million people are affected by sepsis globally, and 11 million people die. What is very silent here are what are the numbers that affect the Latin America and Caribbean region. The last one that came out in 2023 from LAC said 31 million people are affected by sepsis, and there are 6 million deaths. But the region in which I live in, which is the small island developing states, the level of data that is available, even to understand that, it is very, very difficult to get. So what do we do? So the Caribbean faces many complex challenges, one of climate change, one of financial instability or lack thereof, financial stability, and as well as, most importantly, evolving disease patterns such as chikungunya, Mayaro virus, and new diseases. Not much different from our African brothers and sisters. New things arrive on the scene from time to time. While at the same time, with open and porous borders and weak regulatory systems, it allows for the dispensation of antimicrobials on a very liberal basis, or due to financial constraints, the lack of appropriate antimicrobials to treat the relevant things leading to AMR issues. And there's a nexus between sepsis and AMR. First of all, as we recognize, and the One Health approach looks at animals, environments, and humans. And in that, we definitely recognize every single one of these are contributors to sepsis, as well as contributors to AMR at the end of the day. And if COVID did not allow this to be understood fully, and I don't think what else would. We got a real live lab that took place for 2 years in the world, where people recognize that this nexus can actually create significant problems. And COVID is sepsis. Tex has convinced me COVID is sepsis. And one of the greatest sepsis issues that have ever faced the world came through this. But fortunately for the Caribbean, we do have a very, very strong and passionate One Health group. And when we heard about this, we decided, why? Why do we not move things forward? So what are the things that affect both sepsis and AMR? The resistant pathogens obviously becomes very difficult to treat with persons in sepsis, and they become more vulnerable. Surveillance gaps for both sepsis and AMR are lacked in the Caribbean. And most importantly, climate change is a driver of new disease, new vectors, as well as when you have these storms, they're becoming, the wets get wetter, the dry gets drier due to climate change in the Caribbean. We see it on a regular basis, and the storms are a lot more ferocious. The outcomes of those are not very good. So tetanus, all of these things, at the end of the day, leads to problems. So as WHO has said, every resistant infection, so you have resistant antibiotics, increased exposure to potential hazards for sepsis, and you also at the same time have problems in surveillance. So the WHO statement is right. Every resistant infections increases the risk of untreatable sepsis. And hence we have this nexus. And that's why this nexus is important in the Caribbean for us to move forward with AMR and sepsis. So what have we done? Under the inspiration of Professor Kissoon, we started the Mount Hope Declaration. He said we had to name it, we had to own it, and we had to place it. So we named it, placed it, and owned it at Mount Hope in 2024, setting a vision for having an alliance to deal with sepsis in the Caribbean. By June 2024, we developed a comprehensive regional AMR and sepsis education program, and I will give you the stats to that in a little bit. And by 2024 to present, we have established 14 multidisciplinary members steering team committee, which oversees human medicine, veterinary medicine, and public health sectors across the Caribbean to see how we can integrate sepsis and AMR issues within it. To date, we have had some capacity building. Our main team so far has been educational development, youth engagement, as well as recognition of Sepsis Day. 2024, we were lucky enough to have 7 Caribbean countries all mobilized to bring awareness to sepsis as an issue and try to coordinate efforts across the region within the English-speaking Caribbean. We have held 2 flagship conferences, especially the one in Georgetown, Guyana in June of 2024, which marked a watershed moment for us, bringing in significant stakeholders. We have also had some strategic partnerships, again, facilitated by Professor Kissoon, ICAS, and Radbound, whereby we are actually doing joint training across 10 Caribbean countries on EMR surveillance. But again, we are using those to assist in also developing pathways for sepsis surveillance at the end of the day. And a major partner has been the Caribbean College of Family Physicians, who has been working hard with us to get it across the 12 nations which they represent. So we have also integrated into our plans the WHO Global Action Plan on EMR. We have developed ICAS regional partnerships across the 10 countries. We have been working with the PAHO One Health Caribbean Initiative, as well as, most importantly, we have been given a platform by the Global Sepsis Alliance, and we have actually accepted their roadmap and looking towards working in the Caribbean to reduce sepsis mortality by 20% by 2030. We have taken this big goal to move things forward. And we wish to really move things forward in the Caribbean as follows. I will skip this due to time. So what I'd like to let you all know, where are we going? We are looking at region-specific clinical protocols. We are looking at curriculum integration across the UWI institutions, building the surveillance infrastructure, and expanding the leadership for sepsis. The leadership for sepsis cannot be the 14 of us at the moment. The leadership for sepsis has to be built in every corner, every nook and cranny in the Caribbean, because we just do not have the finances and the ability to allow this to just be held by 3 or 4 people, which can drive it. In any project, it takes time, people, and money. And to us, we don't have time and we don't have the money. So we got to improve the people and move with the people. And that's where we intend to do. So through education, through expanded leadership, surveillance, and regional specific clinical protocols. We have some measured impacts, 47 training events, 12 strategic partnerships, 5 national committees, and 850 persons now follow us on social media. We have been able to build over 200 youth ambassadors across the country. And what we have found, we have youth leaders have 3.5 times higher ability to communicate than traditional leaders. What are our challenges? Diagnostic capacities, fragmented data systems, and recognition of the gaps. That is what we are doing and we are pushing for. Finally, what we intend to do to move this forward is to actually increase and accelerate our sectoral networks for learning, youth engagement to ensure sustainability. So when I'm not here, there are people to deal with this. And finally, policy and advocacy moving forward to get it into the back door. This is where we are going. Finally, we expect to have regional expansion, the development of the national action plans across each Caribbean country, the establishment next year of the regional sepsis observatory, and finally, the public-private partnership. We think beyond the Caribbean, we play an important role whereby we can set the roadmap for small island developing states dealing with sepsis and AMR as 2 critical issues against climate change which are facing them. And we do think that we can champion this moving forward. The One Health approach is not optional. It is essential for survival in the Caribbean. In a warming, resistant world, climate change, antimicrobial resistance, and infectious disease, threats do not respect boundaries, no borders, no disciplines, and our response must be equal and integrated with the same level of fervor and as well the same level of education across the board for our people to move forward. Thank you, and this is just our small short presentation.
No, thank you very much, Sandeep, and I hope everyone sort of understands why I'm so proud of what you've done in the Caribbean. I think one thing that is has not been said, you just made a sort of reference to it, the issue of other small islands, but what you're doing also has great relevance to North America. I think the Caribbean is at Empire's crossroads, so to speak, and there's so much travel back and forth and borders are porous. So I think it's very important what we're doing in the Caribbean. North America is not immune to those things. Are there any questions from the floor?
I think there's a couple in the chat.
Yes, so there are quite a few.
Okay.
Questions.
Stephanie, can you read them out, the ones that matter?
Sure. The first one's from Shannon. She was just asking, how is sepsis different in the Caribbean versus other regions in the world?
Oh, yes. Lovely question. I like to answer. Sepsis is sepsis. It won't be different. It's how you deal with sepsis is different. So the ability to access treatment, the ability to prevent sepsis from happening, those issues are where it happens. So at the prevention end, there are problems, and at the treatment end, there are problems. But sepsis is sepsis, regardless of where it is what are the outcomes as well as the inputs. At the end of the day, it's where it's different in the Caribbean.
Thank you. Two quick questions I'll pose to you, Sandeep, and then we'll move on. One from my good friend Fatima Sheikh to say, how are you integrating the justice framework to deal with inequities, I guess, and the engagement of youth and those things in the Caribbean?
Yeah, so beautiful question again. The realities are, at the end of the day, we have targeted youth across the board when it comes to schools, areas, and getting them involved. So what we have done is actually made these youth-driven, youth-led, and youth-purposed. So at the end of the day, we are getting into communities, and it is done actually via lived experience, persons who would have dealt with the problems before. That is something we are doing differently in the Caribbean, where we are going into communities that are vulnerable, NGOs that represent vulnerable groups, and having our youth get them involved into the issues around sepsis to drive it within their communities. The reality is, obviously, that can only happen with so much of funds. And you know, obviously we love to do more, but it is what it is.
Okay, thank you. And Manish has a comment there. We can discuss it offline because he's leading a project in BC, Prevent AMR, which may have some relevance or cross-fertilization with what you're doing in the Caribbean, Sandeep. So we can set up a meeting offline sometime and talk about it.
Yes, Prof. And one thing I just want to say, none of this is me. It's all a fantastic team that are pushing it. Yes.
Well, thanks. Yes, we couldn't have done it without you. You have been a quarterback. So thanks very much. And the final speaker in this is going to be my very good friend, Tom Heymann. Now, I met Tom decades ago, I guess, in Germany or somewhere in Europe. And I remember having this conversation about sepsis. And Tom really could not grasp what was happening in sub-Saharan Africa until I said to Tom, I'm not going to take your money unless you decide to come to me with me to Africa. And he did. And I'm very grateful he did that. And as Tom would say, it's been a great lesson. He is now president and CEO of the Sepsis Alliance in the US. He's led the Alliance for many years and have led the improvement in the recognition of signs and symptoms of sepsis and sepsis awareness from when he started 16% to about 70% across the board now. His site serves over 2 million people. He has launched several different initiatives, including the Sepsis Alliance Institute that has trained over 60,000 people. The Sepsis Alliance Connect, which is a unique platform that has sepsis survivors and loved ones. And I think it's something that we can take note of and do in other areas. Sepsis Alliance Voices, a platform for national and state advocacy, and he focuses on education and training. equity, diversity, and inclusion despite where he lives, and antimicrobial stewardship and innovation. So I think that, again, I'm so excited about this because we have so much commonality between these different countries and different regions that I'm excited that beyond this, we'll carry on. So, Tom, a pleasure to see you. I'll turn it over to you now.
Thank you all. I appreciate the opportunity to be with you today to talk about the importance of awareness. Sepsis Alliance, were founded in 2007 by a dad who lost his daughter, something he had never heard of before. And that is so often the way these types of organizations get started. Carl Flatley was the unfortunate loser of a child, but he gained by starting Sepsis Alliance and really making change happen. At that point in time, there was really no sepsis organization in the United States doing advocacy work, doing awareness work. And at that point in time, believe it or not, Microsoft did not even have the word in its dictionary. Sepsis was a spell check error in the early 2000s, and only 19% of the country had even heard the word before. We work with all sorts of partners, and we, had the wisdom or co-wisdom to launch the Global Sepsis Alliance in 2010, realizing that, as you all have said, borders are permeable, and we really need to be working together if we're going to have a chance to fight and beat sepsis. And the vision is clear: a world in which nobody's harmed by sepsis. We know people will die of sepsis. We don't want anyone to be harmed by it. So here's, a definition. I think the world's getting better at understanding sepsis is not just a bad infection, but it's your body's reaction. It's a complex formula between pathogen plus the body's immune response, which we're beginning to understand a little bit better. Our bumblebee friend is here because I often explain this interaction as being akin to a bee sting. When you get stung by a bee, it hurts, but it's usually not a problem unless your body has that anaphylactic reaction to the bee sting. And then people kind of light up and go, "Oh, I get it. It's two parts." And this is a mnemonic we created so folks would be able to understand the most common symptoms. Kind of like stroke has FAST, we developed the TIME mnemonic, which has been very, very helpful in raising awareness. So the US, common, deadly, and expensive, 1.7 million cases a year, very high mortality rate, 350,000 adults and nearly 7,000 children, more than cancer. Number one cause of death in US hospitals, fully a third of hospital deaths are related to sepsis, and it's the most expensive cost of hospital care and skilled nursing. And this doesn't even include post-acute care, amputations, lost work time, et cetera, et cetera. And number one cause of hospital readmissions, fully 40% of lucky survivors are back in the hospital within 90 days, 2 out of 5. And of those who survive, more than half suffer what could be really called a chronic condition. And I think we need to talk about sepsis as something that is not just acute, but chronic as well. I think that will open up a lot of opportunity for us to talk about it and broaden our constituency. 14,000 amputations each year, number 2 cause of maternal death in the country, and a majority are present on admission, really opening up the opportunity for upstream awareness and early intervention. So most at risk, neonates, younger children, older folks, unfortunately, and those with chronic disease. Amazingly, 129 million people in the US suffer from some kind of chronic condition, so making them more vulnerable. And that's another opportunity for us, I think, to talk to those immune-compromised groups and advocacy organizations. Also at risk, lower income folks who live in rural communities with lower access, racial and ethnic minorities, and those with less formal education. But, be clear, anyone can get sepsis. So some really good news, we track awareness every year. When Carl lost Aaron back in 2002, only 19% of the country had heard the word before. That's a problem if you're trying to fix something. No one's ever heard of your problem. There's going to be very little response to it. So this is a result of a lot of hard work by a lot of people, a lot of organizations, and folks using the word more often when it relates to a death, whether it be Muhammad Ali or Patty Duke or Madonna's run-in with sepsis recently, have all helped in a tragic way help us understand that this is something that's very, very important for us to know about. And that number actually represents 150 million people in the US who've gone from unaware to aware. Some major progress. Earlier today, I heard that there was a conversation about trust and trusted messengers. As part of our survey this year, we asked folks, who do you trust for information regarding your health? Very, very interesting. And probably not surprisingly, my healthcare professional came in number one. Personal connections was a little bit surprising at number two. Nonprofit organizations like all of ours ranked very, very high. And then moving down, government agencies, and I think that's going to continue to erode, particularly here in the US, traditional media, and then social media. Interestingly, social media very, very low, which I took as encouraging that people are not taking what they hear on social media as fact, although we know that that many do, and when it comes to certain medical issues, unfortunately. So our new tagline is infection prevention is sepsis prevention. If you don't get an infection, you can't get sepsis. So let's make sure we're leaning heavily on those things that can help us prevent infections in the first place. We recently ran a campaign to restore some of the vaccine confidence that has been eroded in the United States and elsewhere by the anti-vax community. The Get Vaxxed campaign was something we developed to break through and support people in their deep belief that this is something that they should do for their family to stop sepsis. To your family is your why. You see the messaging there. And we ran this in underserved communities in New Orleans, Mississippi, and West Virginia, where we saw that vaccination rates were particularly low. And we were in out of home, we were in bus shelters. We really took the campaign to where people are. And it's been very, very effective in terms of impressions, and then also folks coming to our getvaxxed.org landing page. We're hoping to create a version of this campaign in Spanish in the next year. So when it comes to getting the word out, there's nothing like a celebrity who is a trusted messenger. And I'm just going to play you a little bit of clip here. I hope the audio works.
Ronnie, you're a living legend, an 8-time Mr. Olympia, the most decorated bodybuilder in bodybuilding history, and the fans simply love you.
I love y'all. I could have never done it without y'all.
For years, Ronnie Coleman gave us strength. 8-time Mr. Olympia.
I am not lying. Y'all the best fan in the whole wide world.
The king of bodybuilding. The man who never backed down. But even the strongest face battles. After countless surgeries, Ronnie is fighting once again. But now the fight is critical. It's a fight for his very life. Now it's our turn to lift him up, to stand with the man who inspired millions. We are all Ronnie Strong.
This experience pretty much shapes my mission in making everybody aware of sepsis, just making them aware that it's out there and there's a term for it, and also it can be cured if caught early. What I want everybody to take away of my story in survival is awareness, because I feel that awareness is the thing that saved my life. Because had my family not been aware of it, who knows what would happen. I am Ronnie Coleman, and I am a sepsis survivor. And if you want to learn more, go to sepsis.org, and also support my movement at ronniestrong.org. Go to Coleman, I am.org, and also support
Ronnie, you're a living.
Yeah. So I don't want to start the video again, but you can see somebody like that. He has 12 million followers on social media, and he's been very, very active in helping to get the word out. As soon as he got home from the hospital, he said, God allowed me to be here. How can I help? And he reached out to us, and he's helping dramatically. I've already met young people who learned about sepsis because of Ronnie Coleman. How else do we get the word out about sepsis? We have a community education kit, Sepsis 911. And several thousand people already downloaded this kit so that they can actually then give presentations in their community, to their church, to their community center, at their place of work, where have you. We need to keep spreading the word about this as a medical emergency. We also, as Tex mentioned, we have a support community for survivors. We'd been hearing from folks for years saying, I'm not doing well, my partner's not doing well, where can I go to get help? And there was no place to get help. And we finally got funding to start, in a part-time way, a community for sepsis survivors and their families to talk to one another, to hear expert presentations, hopefully help with their transition out of the hospital, and hopefully avoid a readmission. And, we thought we might get about 500 people. That was our goal. We're now at over 5,000 participants and growing at about 100 a month, trying to get more and more hospitals to provide this information to families who are discharged, to know that there are free resources that can really be very helpful to them. We also train healthcare professionals on all aspects of sepsis across the continuum of care, and that includes oncology, OB/GYN, first responders, school nurses, anyone who is encountering patients in any care setting, so that they're sepsis ready, they're sepsis aware. It's the first thing they're thinking about when they see a patient who might be demonstrating those key symptoms. We have trained over 65,000 learners already. We're growing at about 1,000 a month. We offer free continuing education, now offer CME. We just got accredited. So free training for folks to become better at diagnosing and treating sepsis and saving lives. We also launched this year a podcast, again, going to where the audience is. We need to make sure every healthcare professional knows about sepsis the way they know about stroke. So it was a 9-part series. We're in the top 10 or 15% of all healthcare podcasts. There was really nothing like it out there, and I encourage you all to check it out at sepsispodcast.org. Again, that is free. And then when it comes to policy, Tex mentioned our Sepsis Alliance Voices. And this is really our effort to leverage. We have about 10,000 patients in our community, 65,000 healthcare professionals, lots of great partners. How can we play a more meaningful role in Washington, D.C. and in the state capitals to make sure that we're getting our share? We're getting our share of research funding, we're getting our share of policy support, and taking a page from the great job the HIV community has done, the cancer community has done, rare disease has done. Sepsis is underfunded, underrecognized as something that is the number 1 cost of hospital care in the country, number 3 cause of death, and this is our effort to make sure that we get more attention from our government policymakers. Here's a picture. We were in DC last month, a bunch of us. We had folks from all over the country come in speaking to their elected officials about this being, number 1 cost. Cost very important to this administration, and it's killing and disabling many, many of your voters. So you need to pay more attention to it. And here I am. I was with Tex and some other great people at a UN side event hosted by the Global Sepsis Alliance, and we had the opportunity to talk about sepsis and non-communicable diseases. Very, very important. Those are the most vulnerable populations, and that was another great opportunity to get the word out. And on the research side, we just held a in-person conference in Chicago, assembling leading researchers in the country to talk about what do we know, what don't we know about sepsis, how can we align our efforts, how can we better convene and catalyze our interest in improving care and becoming more of a force, both on the policy side and on creating a research agenda for sepsis. So thank you again for your time and your attention. I appreciate the opportunity to be here with all of you.
Thank you very much, Tom. I know it's very difficult in 10 minutes to package everything that you've done. I know we just have a few minutes. I know where you ended with going to policymakers and those things in Washington, D.C. And maybe I'd like to pose the question to Sandeep to sort of give his journey in getting policymakers, politicians, to help with his initiative. And then I'll let Manish sort of give his experience in Canada, which is a little more fragmented.
Yeah, so, really and truly, that's why we are moving toward the NNAPs. We have good relations with the ministry in Guyana, the ministry obviously in Trinidad, across also in St. Lucia and Jamaica. However, it has reached a point whereby when you go to policymakers, you go and you speak about how important something is. It's good, but I think, Tom has shown that two important things you need to speak to them about. One, what it will cost them and what it will save them at the end of the day, if we deal with the problem. And the second thing I always recognize with politicians, at least in my part of the world, I've been around politics for some time, you need to always give them the solution on a platter. So you don't go there with something that you need them to do work. You go to them with something that the work is done, just implement, and you can look good. I mean, the key to politics is about looking good, right? That's what politics is about at the end of the day. So make them look good and make them implement. That has just been my short interaction with politicians in my life.
Yeah, and you've been very successful at it. I lean on you in the Caribbean. Manish, any comments?
No, I mean, I guess for us, a lot of the interactions at that level has been either provincially or federally with the sort of the public health leadership, who then directly advise the politicians rather than with the politicians directly. But I think, as you referred to, Tex, with the fragmented nature of things, there's at the national level, there's recommendations that get given, but the implementation is really happening at the provincial and territorial level. So I think for us, we're having to engage, when I talked about the various groups, like we're having to engage at all of those, both of those levels, right, to ensure that things align, because they're not always aligned. So, and I think the questions are different. So at the national level, it's more, maybe a bit more around just, not just, but the science and how, whether these vaccines are working and what the burden of diseases and things. But when it comes to the implementation, then also the provincial burden of disease and the cost effectiveness and those things become more of an issue.
Thanks. Tom, do you want to have anything to add from what you guys have done?
Yeah, we're the federal pathways are very clogged right now, as you may know. They've always been challenging, but now particularly so. And you have cats and dogs who just don't want to play together. Even if it's something bipartisan that can save money and save lives, you think there'd be nothing such a layup as sepsis. So we're turning our attention to the state level, and just help pass some legislation in the state of Maryland. Which unfortunately took the death of a 5-year-old child, but it's turned that energy and that loss into a state law that requires hospitals and the outpatient centers to have a sepsis screening bundle and training and education in place, the Lauchlin's law. And now we're working in our state of New Jersey to do something similar. And I love that advice about make it simple and make them look good. That is that is something to just hang on your wall and rinse and repeat. So thank you for that clear thought.
Yeah. No, thanks. I have one question that I'd like each of you to address, and it's one that I've had difficulty with. In most societies, they're vulnerable population, marginalized, the other, so to speak, poverty and everything else. And there's difficulty sometimes in them accepting what we are saying. We are the academics, we are the elites, etc. It brings the information. And the question is, how do we go about bridging that divide such that they would realize that what we're saying would be in their best interests? And maybe start with Tom.
Yeah. I think you need to know who you're talking to, who your constituency is, and we work with lots of different stakeholders. We work with patients, we work with healthcare professionals, we work with industry, we work with policymakers, and they all have something that they want to accomplish. And I think if this answers your question, we look for the Venn diagram of where are the overlapping interests and where do we have commonality of interest. And I think with sepsis, there is tremendous commonality of interest across all of those stakeholders.
So Manish, in our situation, I guess one of the things that is seemingly tractable at times is engaging the First Nations and in the healthcare, and rightly so. If you look at the history in North America, What advice do you have for engaging vulnerable groups?
Yeah, I mean, I think it's like you say, there's a long history of distrust, so I think it's totally appropriate. And I think, you know, right now, I don't personally have any studies that work directly with First Nations, Indigenous communities, but I think it's really that it takes many years to build those relationships, right? So I think that people I've collaborated with who have had studies with those communities have spent, you know, 5, 10 plus years building those relationships, realizing that it's not one group, it's, you know, you're working with each of these communities individually, and really trying to get as to where they are in terms of what their questions are, and not telling them what questions you want to answer. But I think it's going there openly and trying to figure out what the problems are. And certainly when I've had some of those conversations related to sepsis, infectious diseases previously, you know, there's a lot of dealing with mental health and you know, basic sort of food security and all these other issues that I think it's hard to get into some of these other things if you can't get what, you know, a lot of people would regard and take for granted in terms of sort of the, you know, what you need to survive.
Sure. No, thanks very much. So I think, Sandeep, I'll give you the last word because I think Manish gives you an in also with the One Health approach that you have, that there may be some learnings for all of us.
So my learning is totally off track, everything that is here. I will share, because you asked about politicians. The most senior politician I've ever interacted with in the world was a guy by the name of AGP Kalam, former president of India. He has passed on now, a stellar academic. And he taught me one thing in my conversations with him, and I think it's important to all of these things because it will make politicians move. He always said, when there is righteousness in the heart, there will be harmony in the home. And when there's harmony in the home, there'll be order in the nation. And when there's order in the nation, there'll be a peaceful world. And he said, if you want a politician to move, or you want anything to happen in any way, you got to make what you intend to move forward for that person to understand it's a righteous, conscious decision that they're making. And if you are unable, to me, I recognize that sepsis, and I'm just telling you, Tex came to 3 deans, and I'm just giving you history here. I don't prolong this anytime. 3 deans prior to get this off the ground. And 3 of them told me to speak to Tex, and I never took him on because to me, what he was doing wasn't righteous. Until I understood the equity issues and that sepsis is a disease of the poor. And doing this, there is a need for it to be done, and it can transform lives. Only then I said, all right, this deserves my effort and it deserves my time. And I put it behind it, and I got a fantastic team to work with me. So, Prof, I would just like to say, it's to ensure that people understand dealing with sepsis is a righteous thing. It is something that will make the place better, and then you'll get the equity and people driven to deal with it. So that's my personal experience, and that's the end of my thought, Prof.
And with that, now I'm grateful for what you've done in the Caribbean. I'm grateful to you 3 guys for what you're doing in a different sphere. But I think that this should be the start of the conversation. And I promise when I get back home, we should all 3, 4 of us get together on Zoom and talk about common issues where there could be sort of different exchange of ideas and different exchanges that would strengthen us all. So I'd like to thank 3 of you. Great to see you 3 there. And with this, I'd like to thank also David and Shannon for hosting this conference. They have held firm over the years. They've done stellar work, and I know they have a big team behind them that has been doing this work also. I know some of the players, but I would not call names because I may miss some others, and I'll be in the doghouse. So right now, I'd like to thank everyone, thank those who attended, and I'd like to thank it, send it right over now to David and Shannon for their closing remarks.